Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform. Yeah, good.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Welcome to another year in review. Is that what we were calling this? 2024. This is our review of the best from ESMO 2024 in Barcelona. And before we get into kind of our top from that meeting, a quick fire, James, for you. Do you have any favorite holiday spots or a holiday home anywhere? Or
No
is that
holiday.
private?
No holiday home. Although my mother still lives in North Cornwall, it's a place that lots of people have holiday homes.
Yeah.
So you could think of it like that. No, we thought about that in the past, actually, the whole holiday home thing. And then part of the reason not to do it was the fact that you're then sort of tied down in a way to go to the same place. And I guess we didn't really have the confidence to think that we would necessarily want to keep going back to the same place. So that's one thing. And and also another thing, I mean, this is a ridiculous conversation, isn't it? Because it's such a luxury. Yeah. Another thing is the amount of kind of effort and work that goes into it, even with the best will in the world, it ends up. Yeah. So, and then favorite holiday place? No, I don't know really. I mean, I think most of the thing about holidays is not necessarily about the place. It's more like kind of, I think, relaxing. And I'm not sure that's necessarily place specific.
Fair. I think that's a good answer. Yeah. I think.
Do I ask you the same question, or do we save that for another time?
We can save it. It's okay. Obviously, it's festive themed here, so maybe you can take us through the first couple of top presentations. You were the lead on one of them.
Yeah. So best of 2024, number 2. Okay.
Yeah.
Colon ESMO. All right.
Forgot that part. Forgot to speak the punctuation.
And Christmas tree in the background on the 29th of November, which is today. I think that's early. I don't know, but
we're putting the Christmas tree up. It's less than 30 days.
Yeah, is that the rule?
Well, how much are we giving celebration of Christmas less than 30 days then?
Yeah, I think it's ought to do it before December, but I don't think there's any rules about this. At least there's none I'm aware of. There's that whole Black Friday thing as well, which is today, right? So, but that's just understood.
All over the world, turns out. That's not just in
America. Oh yeah, but that didn't even used to exist. It's like purely commercial invention, isn't it? Anyway, yeah. We digress. All right, so CheckMate 67 final, 10-year analysis.
Well done. Well done with the punctuation.
That's my pleasure. So this links to episode 48 with Jed Walchok, because we were honoured and delighted to have Jed on with us, not just to talk about CheckMate 67, but to talk about his career and his path and everything else. So there's a fuller discussion of CheckMate 67 there. And, before you say it, this trial had been analysed and presented on a number of different occasions, and but this is the final analysis. So I presented the data in, what did you tell me it was? 4 minutes, 59 seconds. Yep. Is that right? Yeah. So it's quite a lot to get through in a relatively short period of time. I guess the headlines are going to be about the OS for one thing. And I have to always caveat this with the business about the trial wasn't designed to compare the nivolumab containing arms, but we could see for the Ipi-Nivo arm at 10 years, OS 43% versus 37% for Nivo mono. And of course, the other thing is the melanoma-specific survival. So the numbers for that 52 versus 44%. The shape of the melanoma-specific survival curves are actually fairly flat for all three arms of the study, and really they're starting to flatten out after the 3-year time point. We knew that already, and then I guess some sort of newer analysis that were done for this presentation and this publication was looking at the people who were free from progression at 3 years. And that's, I think in clinic, that's useful and important. And the people who were free from progression at 3 years really were getting excellent both overall survival and melanoma-specific survival. So if we take melanoma-specific survival for both of the nivolumab arms, it was in excess of 95%, so 96%, 97%. So I think that's definitely noteworthy. There was other analyses by depth of response, and you and I have talked about this quite a fair amount, and it comes back to the whole kind of chasing a CR type idea that we discussed with Tony Rebus. And as expected, at least for me, the people who had the best responses had the best melanoma specific survival. But I guess it's good to see those data. Safety, I don't think anything new. And maybe just the final thing, melanoma-specific survival of people who had grade 3 or 4 AEs. For Ipi-Nivo, 54%, for Nivo, 71%. Probably not time to go into that particular finding too much, but Jessica Hassel picked up that a little bit in discussion, which I think was quite interesting as well. So, for me, end of a long story and a long chapter, because we recruited the study, I remember extremely clearly, late 2013, early 2014. And, like Jed said, I think for me, it just felt like it was a kind of great honour to be involved, actually, and to see the results. And so that's the end of that chapter. Then the other thing right alongside it was 10-year data from KEYNOTE 006. Caroline Robert presented that. So this is Pembro versus Ipi, and this links to our episode 45, where we've discussed it together in a bit more detail. Is there any material difference with CheckMate 67 when you put them next to each other? Not really for me. I think they largely are consistent. Melanoma-specific survival was presented out of this trial as well. And if you look at the Pembro arm, sort of 45% at 10 years, so it's exactly the same type of ballpark. Also, some analyses for the patients who are doing better. And in this case, it was the people who completed at least 2 years of Pembro. So that's a selected group, obviously, people who are responding and haven't had tox and so on. And again, unexpectedly, they're doing very well. So for me, both trials confirm the potential durable long-term benefit of anti-PD-1 or Ipi plus Nivo. And I think that's about all there is to say, unless you want to ask me some difficult questions, which you probably do.
No. I mean, I think obviously both of these studies presented melanoma-specific survival. What do you think about that as an endpoint and how we capture now with the knowledge that we're potentially curing patients? What should we be doing in the future for melanoma-specific survival as an endpoint?
Well, clearly collecting it. I guess the real question, though, is this primary endpoint material at the moment or not? I'm not sure I know the answer to that. But I think with these data sets in this disease, people are taking it seriously. And if we're talking about potentially curative treatments, how can we not measure it? The other thing actually to say, I don't know if I told you this or not, is that disease-specific survival has now been presented for the equivalent trial in kidney cancer, CheckMate 214. Hans Hammer's presented that. I don't know if you know him or not, because he was working in Texas, not MD Anderson though. at a kidney cancer meeting in Nashville just a few weeks ago. Because
Nice.
you've heard me talking about this before, but I've been saying for ages, I think in any disease where we think we have the potential for long-term disease control and cure, we need to be presenting disease-specific survival. And I'd been quite disappointed it hadn't been presented in kidney cancer, but we've now got those data as well. So I've slightly dodged your question, but
No, you can. I mean, it's relevant. I think it's relevant. But maybe I'm about to take us on a little bit of a tangent. I had said to somebody recently, our hospitals have gotten better at staffing pathology rooms with staff. Like I think many years ago, you wouldn't have staffed a pathology or radiology rooms with people to push digital images out to another facility or share slides with another facility, right? But obviously now that's a big deal. And like we're in a modern world where people might need to share pathology, share images, and now staffing somebody to push radiology is a big deal. We really struggled with that in Texas for a minute. In Colorado, our patients are getting their scans in many different states, many different centers across the state of Colorado. And our navigators are able to request the images get pushed over and they get pushed over. A patient seen at Memorial Sloan Kettering, I get the images in a day or two and I can look at the actual images myself. But obviously that requires staffing up those departments. I think in a similar fashion, we're going to have to staff our clinical trials teams with the people who do that long-term survival follow-up, who very carefully, once or twice a year, call these patients. Are they alive? Are they not alive? If they've died, or do we have any clarity on what they died from? Can you read off what the death certificate says they died from? Not that those things are necessarily purely accurate, but that will help us really inform, because I think the other thing that we learned in these long-term follow-up studies is melanoma-specific survival. We were lucky to get that data and captured, but there's a lot of gaps in that data because people are lost to follow-up, but you don't exactly know what they died from, and et cetera, et cetera. And then the shape of the curves and analysis we could talk. Okay, so shall we talk about maybe studies 3 and 4 that we looked at Best of 2024 : ESMO. So NADINA we already talked about in Year in Review 2024 : ASCO as our top takeaway with event-free survival, but they presented NADINA : DMFS. I'm just trying to see how many times I can say it. Distant metastasis-free survival at ESMO, and this was presented by Minky Lucas. So shout out to Minky, but of course seniored by Christian Blank and Georgina Long. So this trial, just as a reminder, showed us an EFS benefit of 83.7% at 12 months versus 57.2% with the adjuvant approach. So they are now giving us 18-month data with a cutoff of 18 months, essentially. Median follow-up of 15.4, but they are landmarking it to 18 months. And you see a sustained benefit in event-free survival, 80.8 versus 53.9%, and a distant metastasis-free survival at that 18-month landmark, 85.7 versus 62.4%. So the real takeaway, and they go through kind of the sites of first distant metastasis, but just recognize that there's been few events so far across the study for distant metastasis, that's still, just really a preliminary analysis at this time. They break it down by stage at recurrence-free survival and distant metastasis-free survival at stage, but recognize this is the stage that they have at pathology because they don't have the stage of their patients going into the study. They stage them at pathology. It doesn't really much matter other than to say, obviously, like, some lymph nodes that you may not know were involved at the time of study entry may look completely normal at the time of pathology. So it's just a caveat there. There was an interesting radiographic response curves. They showed RFS, distant metastasis-free survival. They hold up as expected. The better your response, as you said, same for metastatic disease. The more complete or near complete your radiographic response, the better your survival. But what about pathological response? We know that pathological response can often outperform radiographic response. In other words, you can have people who look like they still have disease radiographically, but pathologically it's all gone. But interestingly, they did not graph major pathologic response versus no major. They graphed each individual. And what you see is there is a little bit of difference here at 18 months between a pathologic complete response and a near pathologic complete response. And Minky was very cautious about this, because there was some separation. She didn't feel genuine to collapse these two curves and make them one curve. There is some separation. Perhaps the best outcome here is to get a complete response, and near complete response does well, but maybe it's not the same as getting a complete response, so it may be beneficial to keep those separate. Maybe we reiterate, or we've said this before, maybe there's an iterative version of path response where we decide a different cutoff for near pathologic complete response instead of 10%. Let's see. All these trials need a little bit of maturation to tell. Still premature for overall survival, of course. You asked me, I think, at ASCO, when will we see that? So we'll see. But anyway, so NADINA study, getting that DMFS in a longer median follow-up is great to see. These curves are sustaining their separation, and it's wonderful. So the other study we thought was good to highlight was the KEYMAKER U02 study. And it was the substudy 02C of KEYMAKER U02. Many people know this study as the umbrella study from Merck, which is testing, it's kind of a platform to test pembro in combination with many agents. And the U02 substudy 02C was specifically the neoadjuvant arm. And so the neoadjuvant arm had previously reported neoadjuvant pembro plus, various agents, and then followed by adjuvant pembro. And in this presentation, we heard about arms 4, 5, and 6, which I believe was pembro plus an anti-ILT4, pembro plus their version of LAG3, anti-LAG3, it's a co-formulation, and then pembro plus atra, which comes out of Colorado Laboratory. Shout out to Martin McCarter and his work. He's one of our surgical oncologists and a great colleague, who showed that atra induces differentiation of tumor cells. And so if you differentiate these melanoma cells, they potentially express more tumor-specific neoantigens, and then pembrolizumab might work better. That had some evidence in metastatic data, and that was presented, or that's been developed into a single center trial at Colorado, and the results will be out there soon. So substudy 02C was looking at these 3 different combinations, followed by surgery, followed by adjuvant pembrolizumab. And I think the bottom line, let me just take you to essentially the kind of efficacy of these. This was a lot of data. By the way, this was presented by Alex Menzies at ESMO. He did a great job going through a ton of data. So you can see in that presentation how arms 1, 2, and 3 did. And for the purposes of time, I won't get into what those arms were. But 4, 5, and 6, this anti-ILT4, anti-LAG3, and then atra combinations each had approximately 25 patients. A couple of them had 26 patients. And you see pathologic complete response rates of about 28 to 42%. And that's complete response. And then if you added in the near complete and path responses, the bottom line is it's really, I'm trying to think of how I want to balance this. If you looked at major path response, again, recognizing that NADINA separated out path complete response from near complete response, but let's just, for the purposes of these small feasibility cohorts, look at them as major versus any type of response other than the major path response rates are anywhere from 32% to 58%. And then other than that, it's really hard to say. The EFS and RFS also look promising, but you can't really separate any of these 3 arms from each other. Nothing specific about toxicities. I think it's nice to see that you see, good pathologic complete response rates with these therapies. They are exceeding, 30+% in these combination arms. And it looks like that co-formulation with LAG-3 seems to be doing well, but you can't really compare it to these other treatment arms, just small numbers, et cetera. But those are the two kind of main neoadjuvant studies that really seem to have some real data. I think honorable mention, we should mention that Georgina Long presented the INMC pooled analysis. That data has now amassed even over 800 patients, and I think even post-ESMO up to 1,000 patients, where they're looking at, certainly across different regimens and all the things, targeted therapy, immunotherapy, combinations, et cetera. It's kind of pooling that data and just trying to make sense of duration of regimens and the role of pathologic and radiographic response. So honorable mention to that.
Yeah, I mean, it's fantastic. I mean, it's good to see those trial designs, I think, with the umbrella. But I've actually got lots of things I'd like to talk about and ask, but in the interest of time, I won't. But I guess the kind of obvious question for me is that, or comment maybe, is the difficulty of picking the winner with these types of trial designs. So yeah, let's move on. So we just talk about CheckMate 76K and KEYNOTE 716, which sort of go together, I think. And that is episodes 9 and 8, respectively, in terms of when we discuss the trials in detail. Georgina Long presented 3-year results from 76K. I won't sort of rehash trial design or anything else, but I guess main comment is I think that the RFS and the DMFS are holding up. Hazard ratio 0.6, roughly 0.7, roughly. The upper limit of the confidence interval there for DMFS was 1.00 exactly. Other comment I think I'd make about 76K, and they showed some data here, is the attempt to try and look for helpful biomarkers. That's obviously really an important effort, but my perhaps slightly negative comment is that this has been going on for a while in adjuvant trials and obviously metastatic trials as well. CheckMate 238 is a good example of that. We now have 7 years of follow-up and a load of analyses, but anything really come out we can use in clinic? No, I don't think so. It would be good if this is different, but let's wait and see. And then KEYNOTE 716, Jason Luke presented this. This was just over 4 years, roughly, of median follow-up. And again, RFS, DMFS holding up. Actually, the RFS hazard ratio was identical, 0.62, to what we've just seen in 76K. DMFS was 0.6 hazard ratio. So for me, very consistent. The other thing that was presented and discussed here was the sort of part 2 of the study. It was the same actually in KEYNOTE 054, that if you got randomized to placebo, you could cross over at progression to Pembro. And again, I think this is a really important study design, but the difficulty, and I said this when I was discussing it, is the interpretation. And I've actually got the numbers here. So in this study, it was called part 2, the crossover part. So 245 patients were eligible for that, but only 80, less than a third, actually enrolled in part 2. And this is not a criticism, but anything that we're then trying to take away from this has to reflect the fact that you've got a load of selection bias in there. And we've talked about this before. It isn't going to be the right thing for every patient to get the therapy if they relapse. When they did relapse, this is a fairly small number of patients. It looked like the efficacy of treatment was about what you'd have expected. Response rate 43%. So that was those trials, and kind of overall comments to Pembro and Nevo look different. No, not for me. I've said that already. They look pretty similar. I talked about a bit about biomarkers already. Both trials are immature for OS. And obviously, this is a subject that keeps coming up time and again. And then finally, this business about the kind of now or later administration of therapy, and we still don't have an answer to that, I think, despite our best efforts. And then that neatly segues into the 7-year follow-up of KEYNOTE-054. You were going to say, carry on.
Well, a couple of things. I'll just mention the KEYNOTE-054. That was a poster presented by Lex Egermont that looked at 7 years, as you were mentioning, pembro versus placebo, with the crossover for those who got placebo. It just shows a sustained benefit in RFS and DMFS as expected at 7 years. But they also reported on this PRFS2, which they might have reported on in their NEJM evidence paper. We might have seen that for the first time, so this was some update. PRFS2.
I might have been an author on it as well.
Oh, so then you know this very well, that PRFS2 is the time of progression after the first recurrence. So it's whatever therapy you get on, it's that progression. So, or it's the time of progression after your first, it's the second recurrence. Oh gosh, how did I write this down? It's time for randomization until second recurrence. Yeah. Or progression of disease from your first recurrence. Does that track? Did I say that as well as possible? Or death, of course. It's the S in PRFS. They show that there's potentially even a PRFS2 benefit, but there's some controversy over that as an endpoint. Just I'll say that and leave it at that. And have I asked you this before? In our adjuvant studies of checkpoint blockade, IPI or PD-1, do we know if ulceration is a biomarker for that?
I can't answer that off the top of my head, but I'm almost certain it's been looked at, and I'm as confident as I can be that it's not a useful biomarker. Okay. Because I think, because sort of harks back to all the interferon stuff. I'm now getting visions of Lex talking about this. But now I don't.
With those red trousers.
Sorry?
I know. It's visions of Lex in those red trousers, I know.
Yeah, which he seems to have given up. Actually, I don't know if he lost his pair of red trousers or something somewhere, but he wears green obviously sometimes now. Yeah, we must ask him about that sometime. What exactly is going on? So no, I don't think so anyway about ulceration, which is a shame, but nevertheless, again, important to look. So I'll go on.
Yeah, I was just going to say, I forgot to mention in the NADINA, the talk of NADINA, that's episodes 26 and 27 in our archives. So if anybody wants to hear the original reporting of NADINA, discussion with Christian, and then our take on it in the real world, that's episode 26, 27. We had not done a previous episode on KEYMAKER U02, so this is the first time.
So real-time intra podcast fact check, like it. Okay, so we're done. I'd say happy Christmas, but it's November the 29th.
So fussy. It'll be later than that by the time we publish it, so disregard these comments.
As ever.
All right. Thanks, James.
Take care.
See ya.